a lot of the athletes now, they have a new needle arthroscopy, so you can, like the size of a needle that has a camera on the end of it, so you can actually do procedures with no downtime.
That's like the it's like the MRI through the cam, though. It's just a cam.
Better yet, it's like it's me looking at it through the camera, so we can visualize it, and the patients can stay awake and see about it, or we can turn the fluid on, and even kind of like if there's any cartilage damage or meniscus tear, we can address it right away with no downtime. You know, so that's what a lot of pros are getting. I know that certainly the Patriots were doing that for their assessments, and the guys wouldn't have any downtime. They do it all in the office, and that people wouldn't have to know. And I think certainly, like if you have a meniscal tear and you're at that high level, don't want to miss work, that's certainly an option for you. Or, you know, then you don't have to undergo a full surgery and the risk of that. So, like, you know, what's the recovery time? It's minimal because you're awake. It's like just getting your teeth pulled. And so what we're finding is that the knee needs a healthy joint, as we're kind of considering like an organ. So it has to be like taken care of, healthy. And if you don't take care of it, like your liver, then it's going to start to fail on you. But then, you know, that's not really the long-term solution. Just let it fail and replace it. And so now we're actually kind of getting smarter with the cells, you know, treatment options in terms of physiological recovery parameters, managing the kinematics, and doing, you know, higher level therapy, but also adding the medications in terms of the therapy. the PRP, and even if you have a focal defect, like if you have a cavity, we looked in terms of the physical examination, and there's, you know, specificity and sensitivity, the accuracy of physical exams, right? Which is pretty important because in theory that's an important part of the medical diagnosis. So what we did is we did a study and said, okay, what are the higher quality studies out there that would help us diagnose the biceps? And we found that actually if you do one, it's pretty good. But if you do two, even better. Kind of makes sense, right? Because like, you know, if one is better than two, but actually if you add three, it just creates enough chaos that it's actually no longer valuable. So you should do one or two together. And if both are positive, then what's your accuracy, especially in certain situations, right? And so we actually found that, you know, by doing those examinations, which were way more accurate than the MRI. Right. For me, like my simple knee arthroscopies on average are 5 to 10 minutes. So that's like, you know, not very invasive, 2 small poke holes. And for me, a lot of that is just because you're going in there to figure out what's going wrong, to diagnose a problem, to quantify what exactly is. Because a lot of my patients, probably the same situation, car accidents is tough to diagnose, right? There's a direct trauma that nobody really remembers because they're focusing on other things. Many times there's other injuries that's kind of been the focus. You know, there's other significant pain generators. But, you know, it's been 3 months, they can't work, they're having pain going up and down stairs, and then you have an MRI that's, you know, reasonably helpful, but not fully comprehensive. And then there could be, you know, an unhealthy joint, just the fact that it's not healthy, right? In terms of like the chemicals are off. And then number two, there might be actual biomechanical. They're not walking right. They're limping. They have to kind of retrain their brain. Or frankly, what I see is that they actually do have cartilage damage that needs to be addressed. But at the same time, is that as your chest is moving forward, assuming you're like hit from the rear end or like going to, you know, you're moving forward, you go to a stop, your body has inertia that carries it, right? And so this is going back to the long head of the biceps. The long head of the biceps is what I would consider as like a seat belt on it, because when you get hit, you contract up, right? And so you create a force through your biceps, but at the same time, the inertia of your body is sending you through. So you're actually squeezing your muscle, but your body's inertia is pushing through against that tendon, which oftentimes causes the tear, right? And then so the biceps tears, and then right after that is the rotator cuff. And so there's actually 4 muscles of the rotator cuff. And what I oftentimes see is the muscle on top is the supraspinatus. That one is the most commonly damaged. And then there's one in the front called the subscapularis, and that I'm seeing torn in the younger guys, right? And so, you know, if the one on top is a little bit weak as we get older, that's probably the first to go. But usually the younger guys, especially as they're contracting pretty hard, they tear that muscle too. So you have to go in there and kind of see. And so I give the analogy, if you had a rope, and the rope is kind of like what you're using to pull your arm. And if it's partially torn, say 50%, all that force is going through the half of the tendon, so the pain goes up because it's being overloaded and likely to fail. And so there are some things that are new technology where you can put a patch on to heal the rotator cuff. Many times we'll actually put a stitch in to reattach the tendon to the bone, which is just a suture. And now we have they're considered anchors, but they're like screws that are made up of the same composition of bone. So it actually makes it pretty well, because then your cells kind of grow into that, and then they'll grow into the tendon and create healing. So that's pretty unique.